So, good afternoon. Today we are going to discuss a neurological case, paraplegia. So, we will be presenting it as a case and then we will discuss it. And mainly, this is intended for the undergraduates. Thank you.
Can start it.
Yeah, Dr. Manoj will be presenting the case and we will have discussions as per the presentations. But initial part, he will present the history and then we will discuss it.
Yes. Good afternoon. So my name is Manoj. Finally, I'm PG resident in general medicine. I'll be presenting a case of paraplegia. So demography, it's a 48-year-old female. It's a homemaker coming from Palluruthi, Cochin. Right-handed individual. Informant is the patient as well as the husband. Both are reliable. So chief presenting complaint was a difficulty in walking since the last 14 years. So history of presenting complaint. So she was apparently asymptomatic 14 years back when she developed difficulty in walking. It was gradual in onset and progressive. Initially she found difficulty in walking alone and she was requiring support or a walker to initiate walking. So now it has progressed to an extent that she is bedbound for the last 4 months. So initially the weakness started developing in the right lower limb first. She had difficulty in lifting the leg, which led to dragging of the right leg with tripping on small objects associated with stiffness. So she subsequently developed difficulty in getting up from sitting position. So she also gives history of inability to hold the urine for long, and it's more during the night. It's associated with incontinence, hesitancy and urgency. So then the weakness has progressed from the right lower limb to involve the left lower limb, and again it is associated with the stiffness. Previously she had a history of tripping and falling and sustaining a fracture to the right humerus, which is requiring a surgery. So coming to the negative history, so no history of trauma, headache, vomiting, seizures, no history of buckling of knees, slippage of chapels, ataxia, numbness, paresthesia, loss of sensation, no difficulty in lifting head of the pillows, no history of wasting or any fasciculations, no history of cognitive or behavioral issues. So coming to the past history.
Yes.
History of fracture of the right humerus, which requiring open reduction internal fixation with intramedullary nailing, which was done in 2010. No other comorbidities like type 2 diabetes mellitus, systemic hypertension, dyslipidemia, coronary artery disease, any thyroid illness, tuberculosis and human immunodeficiency virus. Developmental history was normal. Personal history, she is married, P3L3, mixed diet, normal sleep, no history of any drug abuse. Bladder, inability to hold urine, sensations are normal. Bowel, intermittent constipation present.
Able to eat well.
Yes, appetite is normal.
Suspicion of any nutritional problem leading to neurological disease.
No, sir.
So,
Yes.
Then, what about the family history?
Sir. Family history. So, paternal sister having a similar complaint, or since her 40 years of age.
There's no details.
No details for the details
available. Told by the patient.
Yes.
Right. Okay. Sure. What about her personal life?
Her personal life, P3L3, so three children are
married, three.
No complications during pregnancy, non-consanguineous marriage.
Okay.
So menstrual history, she attained menarche at 14 years and menopause at 47 years of age. And bleeding was regular during that time. No other complications. So with this history and past history, I'll give you a summary. Now this is a 48-year-old female with no known comorbidities, presented with complaints of difficulty in walking since the last 14 years. She is not able to say a particular time when she initially got the deficits. So over the 14 years, it has gradually progressed from the right lower limb to involve the left lower limb associated with stiffness. So she has history of tripping and falling as well as sustaining a fracture to the right humerus. So along with that, incontinence is there, unable to hold the urine for a long time, urgency, frequency, and constipation is also present. So this is the summary.
And she has got the capacity to know the
Yes, bladder
bladder
sensation is
symptoms,
normal. Sensations are normal, but she's not able to hold it for long.
Okay. So when you see such a case,
Yes,
the first thing that will come to your mind is it a neurological problem or not?
yes,
From your history, it is evident it is a neurological disease that led to weakness of the lower limbs.
yes,
Now, the next important thing that you should think is it a cortical problem that led to weakness of the lower limbs, or is it a spinal problem that led to the lower limbs?
yes,
Have you got some idea about that, Manoj?
yes. So based only on the history, so the localization, first in neurology, first we have to say, is it a neurological problem like certain, and
That
next is where is the
okay.
localization. So it can be a cortical as well as the spinal level. Here, what makes me think more of cortical is there is no definite sensory level, what she's saying, and no sensations abnormalities are there for the patient, history wise.
That's actually difficult, but there are diseases in the spinal cord also
Yes,
without a sensory level.
yes.
Okay, so you have to consider cortical also according to you.
Cortical plus spinal cord.
Then, is there any point with which you can consider cortical signs here?
Yes,
Because this is actually belonging to the medial surface of the frontal lobe.
yes,
So invariably you will get some dysfunction of the frontal lobe.
yes.
Have you got any such signs?
So frontal lobe, mainly the initiation center for the micturition is present. So the pontine micturition center is there, the overhead control is there. So it usually inhibits it. So if that inhibition is lost, she'll have that.
Yeah, that you are telling correctly. Your bladder actually much more than loss of inhibition.
Yes.
So the bladder symptoms are not suggestive of cortical frontal. That is very good. But any other frontal, because speech also is involved in that.
Yes.
That's a frontal lobe. Then personality disorders.
Yes.
Cognition disorders.
There was no speech abnormalities, no cognition or behavioral abnormalities.
So no frontal lobe signs. History.
Cortical signs.
So that helps us.
Yes.
To reconsider that part from history wise only. Then coming to spinal cord diseases.
Yes.
What is favorable for spinal cord is no upper limb involvement, no cranial involvement, nothing like that.
Yes.
Then history wise, is it possible to say the onset of the disease?
So it's very difficult.
Correctly.
Because she doesn't know the exact date. It was gradually difficulty she found gradually, and then it progressed. So particular date she didn't find it, but difficulty in doing her regular activities.
This is because in a vascular accident or a compressive myelopathy, it will be easy to pinpoint to the onset and progression, with which you will say this is possibly due to vascular or compressive or demyelinating like that.
Yes.
So that approach is not becoming successful in this patient because the disease or the disorder is very slowly progressive. Okay. And then you have to inquire whether this belongs to degenerative disorders, it runs in families,
Yes.
or is it due to metabolic disorders, or it is due to similar illnesses, compression like that. So can you consider this as anything that runs in family?
Yes, sir. Like because of its duration of the illness, along with not specific time we can localize. Like it's more like not acute or it's not a subacute. So the differentials for acute and subacute are different.
So like this is actually a chronic course.
So it's a chronic course. So and it hasn't improved and it's worsened.
That's right.
So more likely it will be some kind of degeneration, just running in the family.
One more point that supports. Another person had a similar illness possibly.
Paternal sister had a history, but details are not much available.
So this is a paraplegia that possibly is running. Then you have to exclude. And also you should consider other reasons for paraplegia. Meanwhile, what is important for the student is it a spastic paraplegia or is it a flaccid paraplegia?
Yes. So history wise
Means spastic means it is purely pyramidal involvement. Okay, human type you always. The other one is once it is flaccid, it can be
spinal shock or
it is a human. This is very good. Spinal shock or
can be an element.
Element types you should consider.
So element means then we have to consider from the anterior horn cells.
Yeah, anterior horn cell disease like polio. Polio can present like this,
motor neuron
or
disease.
No, the other one is modern GB. What we say Guillain-Barré syndrome. Guillain-Barré syndrome. That's very important. When you consider these two, actually the polio is a disease of meninges.
Yes.
It's mainly meninges. So classically it presents with the meningitis signs on. So we will get history of such thing and you will have many contacts or something. Anyway, it is eradicated, but even you should know this was the problem previously. And now the other one is
GBS. Demyelination.
So usually there will be an infection either preceding illness, something like that. In this case, there is no need to consider, but when you discuss such a case, you should also throw some light into that aspect. That's why you are discussing. In our case, no, definitely it is not. But when another patient comes with rather acute history and there is a symmetry, and it is ascending type, you will consider
Guillain-Barré.
And what will happen to the bladder?
So bladder in that case will not be initially
involved. Usually, rarely only, very rarely only bladder involvement in GBS, Guillain-Barré syndrome. So symmetry, then flaccid paralysis.
And it will be acute.
Yeah, and it can also ascend, depending upon the cases. Right. So is it, what type of your patient, flaccid or spastic?
So history wise she is telling there is stiffness in both the lower limbs.
So that indicates it is a spastic paraplegia. Is it supporting your hereditary type?
Yes.
That is also supporting. Then why can't you consider demyelinating disorders?
So first thing is
multiple sclerosis.
So multiple sclerosis.
Again,
the other history is there will be like new onset, some deficits will be there, which is not particular time. So it will be difference of time and difference in the area also. Involvement will be.
So it will be multiple time, multiple sites. That is classically seen. And also eye involvement is common in a peculiar group of patients. So it is a autoimmune nature of the disease. And a different time and different types. You should consider if it is available. Otherwise it is a first onset one. Then transverse myelitis also presents with the
same problem.
What are the classical viruses that can produce myelitis? One is our varicella. Varicella is well known to present with herpes group. And HIV is also known to produce myelitis. That's also important. So these viruses can produce. Another one is our the other one with significant lymphadenopathy. Epstein-Barr virus. Epstein-Barr virus, varicella. These are very important when you consider viral myelitis.
Because they will be in the dorsal root ganglia and reactivation.
Okay. So always consider that if the history is supporting that, this is the case, invariably not. Okay. So in our case, support is mainly for inherited
degenerative kind of disease rather than.
So when you discuss a paraplegia, you should also consider compressive myelopathies. Have you got some idea about compressive myelopathies? When will you consider a compressive myelopathy?
So history will be more like if it's a compressive myelopathy, history of first trauma should be ruled out. Then
the first
pain localized to the region where it is involved.
Spinal pain. You say that only. Spinal pain. Spinal paraplegia, first point is spinal pain. Even if it is tuberculosis also, there will be some involvement of the one, spinal pain. Trauma also, spinal pain. Good. And what about sensory?
Sensory, spinal level means it will be a definite sensory level. Patient will be able
first is pain, local pain, focal pain. Second is sensory level. What is the third point? If you consider about bladder.
Bladder involvement, if it's...
What type of a bladder you see?
It will be more of an element bladder.
Depending on the site, even then...
Depending on the site.
I'm telling you, I need not say lemon. This is actually when there is a mid-thoracic level involvement, T6. What happens is the orders from the cortex and communication with the pons.
Yes.
Cortical inhibitory center, as you told, rightly pointed out, and also the frontal, pontine facilitatory. These are not communicating with the bladder.
Yes.
So that means there is no administration coming down.
There's no.
So what will happen? Spinal cord will act. The reflex center will be in the spinal cord. It will start communicating with the bladder muscles and act its own.
Yes.
This is what is called automatic bladder.
Okay.
This is an automatic bladder. Means the reflexes will operate within that. So what will be the administration? Because it cannot have capacity to order. You store up to 1 liter or 2 liter. It cannot order.
Yes.
So it will say when there is 300 ml or so, the spinal cord will order empty.
Yes.
That means the frequency will increase, urgency will increase. Yes. Whereas just now you told about LMN. LMN means the bladder is not having an idea. Means it is getting filled.
And overflow.
And then overflow. That is what is called autonomous bladder.
Okay.
It is an autonomous bladder. This is automatic bladder.
Automatic bladder.
Okay. So autonomous bladder is the one that overflows and incontinence occurs. That is LMN, classical type. So these three are the most important one. One is a cortical bladder. Yes. Second is a spinal bladder. That is automatic bladder. Third is autonomous bladder.
Autonomous.
So if the patient has no idea about that, it fills and dribbles.
Yes.
This is it. So our patient has got any is belonging to any of this?
Yes, sir. Our patient mainly is having
is he able
increased urgency and difficulty to hold the urine.
Yeah.
But sensations are normal.
So that means it is a automatic bladder.
Automatic bladder.
Low frequency, the frequency is going. Anyway, she had this time complication with urinary infection. So may not be able to predict the spinal type or what type bladder it is, because another focus of irritation increasing the frequency. So in urinary infection, because of the bladder wall irritation, there is increased frequency. Okay, so proceed.
Okay. Next, just talking about the innervation of the bladder.
Yes, this is actually the students often get confused, or whenever we ask questions about the nerve supply of the bladder, see this picture.
So bladder, the sympathetic nerve supply is coming from L1, L2, L3. So from the sympathetic chain and goes there. The parasympathetic nerve.
See the supply. You can one is to the bladder wall, the other is to the
internal urethral sphincter.
So what will happen when the bladder is become full?
Yes. Yeah. Initially, when the bladder is becoming full, there will be sensory stretch receptors that will get activated and goes through the parasympathetic nerve.
Good.
And then the efferent also comes through the parasympathetic nerve and causes contraction of the detrusor muscle and relaxation of the internal urethral sphincter.
So the parasympathetic will be contracting the bladder.
Facilitation.
So same time there should be internal sphincter should relax. Mainly by sympathetic, and also then the external sphincter. Yes, it is supplied by the somatic
pudendal nerve.
So that also automatically, voluntarily you will relax. That is how it functions.
Yes.
Good. So this picture is very important. The parasympathetic S2, 3, 4 and the pudendal, that is somatic. The other side lumbar.
Yes.
Okay, sympathetic chain. And there is a ganglion by name hypogastric ganglion. Nice.
So coming to the examination, so patient is conscious, oriented to time, place and person, moderately built and nourished, pallor was present, no icterus, cyanosis, clubbing, lymphadenopathy or edema. So left ankle, there's a pressure ulcer, just 2 into 2 centimeters. Bilateral sacral region also grade 2 pressure ulcers are present. So she's a right-handed individual, she is catheterized currently. No obvious neurocutaneous markers are present. Vitals.
Continue.
Pulse rate is 80 per minute, regular rhythm, normal volume, character, condition of Wesenwald. So no radio-radial or radio-femoral delay. Peripheral pulses are palpable. So blood pressure is 110 by 80 millimeters of mercury. It's measured in the left arm in supine lying down position. Respiratory rate is 18 per minute. It's thoraco-abdominal. So temperature is 98 degree Fahrenheit. Measure in the axilla. So coming to neurological examination, higher mental functions. So she is conscious, oriented to time, place, and person. Speech and languages are normal.
So just cover in the abdominal only you just mentioned. Attention, everything is normal.
Then cranial nerves also didn't reveal
anything. No obvious cranial nerve abnormalities. This is important because in demyelinating disorders or in B12 deficiencies,
posterior
column involvement, or in syphilis, there can be second cranial involvement.
Yes.
Okay. Motor system?
Bulk is equal bilaterally. Tone in upper limb, it's normal. But in lower limb, it's more spasticity. In bilateral lower limbs.
How will you elicit spasticity?
Sir, spasticity is velocity dependent.
So that means only one group of muscles
will be involved.
More.
So classically,
so it is a type of hypertonia.
Yes, one group of
seen in upper motor, that is pyramidal tract lesions.
Yes.
Where one group of muscle will have increased tone. That is demonstrated by velocity dependent movements. That's all. What is the classical example?
So classical in hemiplegia. Upper limb there will be flexion response and lower limb will be extensor response.
Good. Fine. So in this case, both sides it's spastic type. That
only
means
lower
both sides corticopyramidal tracts are involved. Pyramidal involved. Good.
With normal upper limb tone. Coming to power, neck muscles, power is good. Upper limb, shoulder flexion extension is normal. Elbow flexion extension is normal. Hand grip is also good bilaterally. Small muscles are also
upper limb is fine. Lower limb.
So coming to lower limb, hip. Question was more of a flexion attitude of the patient because of spasticity. And hip flexion extension, it's 3/5.
There is involvement of the flexion.
Knee is also bilaterally 3/5. Ankle is 3/5. Trunk muscles are good. Beaver signs is absent.
So hip flexion is tested by flexing the hip towards the abdomen, and you will apply resistance against.
Yes.
Right.
Extension by keeping either in the heel or in the...
So underneath the heel you will keep your hand, then you will ask the patient to press. Or patient in the prone position
and ask them to lift.
Extend. Fine. You are told about Beaver's sign.
Nice.
What is the importance of Beaver's sign?
Sir, actually it's more like
it is a predictor sign of
spinal cord involvement. So mostly it's a T10 involvement.
So when there is a T10 lesion,
so what happens is the umbilicus is applied from T8 to T12, that region.
Yeah.
So when we ask the patient to flex the neck against resistance, in normal individual, the umbilicus is not pushed anywhere. In case of a lesion which is present at the T10, because of overactivity of the upper abdominal muscles, there will be umbilicus.
So the contraction of the upper muscles will pull the umbilicus up. Yes. When the patient tries to get up from lying down. That's very good. Okay, it's a spinal localization.
Yes. So coming to deep tendon reflexes, biceps and triceps supinator all are 1+ bilaterally, whereas there is knee jerk are 3+, ankle jerk is also 3+, and clonus is present bilaterally.
So usually you will express the findings of deep tendon reflexes as 0, 1, 2, 3, 4.
Absent, present.
0, 1, 2, 3, 4.
Absent, present, brisk, very brisk, clonus.
Absent, present, brisk, very brisk, clonus. 0, 1, 2, 3. Here actually 1+, 1+. That is almost normal in the upper limb. In the lower limb it is exaggerated, and even clonus is present in the angle. Good. That is again supporting bilateral pyramidal corticospinal.
Coming to sensory examination, sensory more or less it's normal.
No, normal sensory.
No cortical signs also.
So in case of a cortical paraplegia
yes.
and a spinal paraplegia, that point we forgot to tell.
Yes.
In a spinal paraplegia, if it is a total spinal involvement, there is a definite level.
Yes.
Spinothalamic involvement is there. And the level and the, since inside and outside is almost matching. Whereas in a cortical paraplegia, the motor homunculus and sensory homunculus differs.
Yes.
Motor homunculus is almost full up to the hip level. whereas the sensory is only very much lower in the lower limbs.
Yes.
So you will not get a corresponding
Definite sensory
sensory deficit in
Cortical.
cortical paraplegia. You may get only below the knee.
Yes.
That is very much supporting cortical
No.
paraplegia. Yes.
So no cerebellar signs, no postural hypotension. Spine, there is no kyphoscoliosis, gibbous or tenderness.
This is very, very, very important in spinocerebellar disease, motor degenerative disorders. More findings will be there, but in this case, there is no involvement. Nice. So you have to invariably examine the spine. And also look for the peripheral nerve, and also you should examine carotids. This is very important. And postgraduates are supposed to see the optic fundus also.
Yes.
Nice.
So
after examination, once again you have to tell the summary, and which here it is.
Yes, so it's a 48-year-old female with no known comorbidities, presented with complaints of difficulty in walking since 14 years. So it initially started in the right lower limb and progressed to involve the left lower limb. It's associated with stiffness. She's also complaining of increased inability to hold the urine for a long time, along with increased frequency and urgency. Along with, she is giving a past history of tripping and falling and sustaining a fracture to the right humerus.
These are the complications. Long-standing bedridden patients develop thinning of the bones. That means loss of calcium from the bones,
yes.
Osteoporosis, and this leads to fractures. Vitamin D deficiency contributes.
Yes. So with the examination, she had pallor, grade 2 pressure ulcers, bilateral sacral area, and systemic exam revealed bilateral lower limb spastic paraparesis with predominantly flexion attitude with brisk exaggerated deep tendon reflexes along with clonus, and extensor plantar reflex bilaterally.
Right.
Plantar is extensor.
Extensor bilateral. So again, that is contributory. So when you consider a paraplegia,
yes.
When you compare upper motor neuron, lower motor neurons, lesions, this is very important. In a lower motor neuron, all reflexes are absent. Whereas in a upper motor neuron, especially pyramidal tract lesion, deep tendon reflexes are exaggerated, superficial reflexes will be lost. And the plantar becomes
extensor.
This is a very important finding with which you can say this is paraplegia of spinal, that is UMN pattern. So coming to the diagnosis.
So it's a spastic paraparesis due to probable degenerative disease.
Here we will consider hereditary. So
because of
we will add. What else we want to add? Hereditary spastic. Hereditary. 1 point. Another thing, you should also include other comorbidities.
But no comorbidities.
Then functional status. What is the functional status? You just write FS. FS, that is a functional status is able to move around with support or without support.
Yes.
Period.
Able to move around. Now she is bedbound.
So unable to move around
with support.
Herself.
Without support.
Requires help and support. Help and support. Then comorbidities, if it is there, you have to write. So where is again you have to write where is the degeneration. He has written spastic paraparesis. The site also is important.
Yes.
This is mainly in the spinal. So mainly the degeneration confined to the spinal cord. Is it there upper limb involvement?
No, sir.
No. That means it is below?
It's below T1.
That also you can mention. So it is below T1. So when you write a diagnosis, etiology should be there, pathology should be there, then the site. So first question in neurology is where is the lesion? Second question in neurology is what is the lesion? Here we have satisfied all this. This is enough for diagnosis, all these points. So thank you, Manoj. Now we will put some more points about how to examine, means how to elicit some reflexes. That we will take now.
So when we are considering a paraplegia, we have to first know whether it's a spastic or a flaccid paraplegia. So spastic means morely the involvement will be brain or a spinal cord. Flaccid, it will be spinal cord. It can be starting from the anterior horn cells. It can be nerve root. It can be a muscle, neuromuscular junction, anything. Then this is the cross section of the spinal cord.
Good, very good. That is very important for undergraduates.
So this image we are
Just
seeing,
first you just show them that cortico or important tracts. First corticospinal you show. Where is that corticospinal?
Yes. So corticospinal tract is this one.
Yeah.
Because
That is the most important tract.
so corticospinal tract is anterior as well as lateral. So lateral more 80% of fibers will be there, 20% will be in the anterior. Decussate at the lower end of the medulla. And the representation is from inside to out, it is cervical, thoracic, lumbar and sacral. So this thing is important when there is a lesion confined to the spinal cord, whether it's an extramedullary or an...
Then you say how the spinal cord can be compressed from outside and inside.
Yes.
So you can just mention that using that picture.
Yes. So spinal cord involvement can be intramedullary or extramedullary, and this medulla means is the substance of the spinal cord. So extramedullary can be within the dura or outside the dura. So when there is a compression from outside, so the earlier involvement will be the sacral region, followed by the lumbar, thoracic, and last will be the cervical region. This is more of the upper limb. So this representation is important. Next, coming to the spinothalamic tracts, which is lateral spinothalamic tract and anterior spinothalamic tract. So spinothalamic tract, it's also the same representation. The cervical area, which is more into the spinal cord, which is more in the medullary, and followed by thoracic, lumbar and sacral. So any extramedullary compression happening will compress the sacral region initially, which is followed by later involvement of the cervical region. Whereas this is opposite in case of the posterior column. Posterior column, fasciculus cuneatus as well as gracilis, lateral and medial. So posterior column sensations are basically vibration, joint position sense. Here what happens is cervical, thoracic, lumbar and sacral. So when there is an external compression, all will be involved. So this joint position sense as well as vibration will be involved in both the upper limbs as well as lower limbs in posterior column involvement. Whereas like I said in lateral spinothalamic tract and corticospinal tract, the earlier involvement, if in case of a compression from outside, will be the lower limbs and last will be the upper limbs.
Nice. So what are the situations you can get an extra? So what you mean extramedullary means outside the cord proper.
Yes, cord proper.
But inside
the dura.
That is extramedullary intradural. That is the point. Another one is extramedullary extradural. For example, if there is a vertebral body problem, it is both extramedullary extradural. What is the classical one that involves in that? What is the disease that
most common in our country is tuberculosis.
So tuberculosis is the most important one, or even secondaries from the malignancies.
It can be an epidural abscess.
So it can be even staphylococcal infection, osteomyelitis group. And brucella is also well known, but very rarely it produces a neurological problem like this. But tuberculosis invariably, malignancy also can produce. Then abscesses are very important. Extramedullary, intradural. So epidural abscesses are very important when you consider extramedullary, intradural. Then meningiomas.
Then neurofibromas and meningiomas are also differentials for extramedullary, intradural.
Then have you heard of weakness due to cauda equina and conus medullaris? Yes. Can you just demonstrate here?
Yes.
Cauda equina and conus medullaris.
So first we will have the anatomy.
It's a beautiful picture.
So this is the conus medullaris. That is actually the spinal cord ends at the lower level of the L1 vertebra, but the spinal segments extends below also. So here this is the lower portion which ends at the lower border of L1. So this conus medullaris is comprised of the sacral as well as the coccygeal. So this portion is known as the conus. Whereas cauda equina, all the nerve roots which is exiting, and then corresponding to the vertebral column which is coming out from
So
L
that
to
means the lumbar and sacral,
sacral and
all these fibers together, just like a tail of a horse, is called
cauda
equina. That's very important. So if there is a lesion, can it uniformly press all this? No. These are all actually outside the code proper, that is LMN. So your findings will be LMN type. Means cauda equina means LMN type. So it cannot uniformly involve. That means asymmetrical bilateral involvement and LMN type. That's very good.
Conus, same way. It's more like a spinal cord proper. So it will be more like an UMN type of.
So because it involves the S1 and other thing, it can produce an upgoing plantar. So an upgoing plantar with sometimes only a level you can get because it is quite low.
Yes.
Upgoing plantar, and to some extent there can be symmetry.
So, and the difference is in cauda equina involvement, because L2 and all is affected. The knee jerk will usually be affected.
So affecting the knee jerk is very common, but it will never be symmetrical. So symmetrical, more root pains, again with the absent upgoing plantar. In another group, there can be an upgoing plantar. Yes. Then what about the incidence of impotence?
So impotence also more common in case of a conus medullaris syndrome, whereas in cauda it's less.
Very rare. So conus also can present with the impotence. So bladder involvement also depends on the type and severity of the lesion.
Yes.
Again, you know, S1, 2, 3 is the one involved important segments for bladder. So that segments are involved in this only. So bladder involvement is common
in conus
medullaris along with the impotence also. Yes. So age is very important when you consider impotence. This is what is about conus cauda syndrome. Anything from the vertebra or here abscesses, vertebral disease also can produce this type of this secondaries. This disc, endovertebral disc, all this can produce compressive myelopathy at that level.
Just to tell about the difference between conus medullaris. So spinal level involvement is the sacral cord segments and the roots. In cauda equina, as I told, it's from the lumbosacral nerve roots, L2 onwards. So radicular pain is less severe in conus and more severe in cauda. Motor strength will be symmetrical, less marked and hyperreflexic. And cauda, like sir told, it's asymmetrical areflexia. Along with atrophy is common because it's more likely an element. Deep tendon reflexes, ankle jerk is affected, whereas knee jerk is preserved because the level is from S1 to coccyx. Whereas in cauda equina, both knee and ankle jerks are affected. Sensor level is localized to the perianal area. It will be symmetrical and will be bilateral. Whereas in cauda equina, it will be localized numbness in the saddle area. It will be asymmetrical and it will be morely unilateral. Sphincter involvement, early urinary and fecal incontinence will be present, whereas it tends to present late in case of a cauda equina. And impotence, like sir told, frequently seen in conus medullaris and less frequent seen in cauda equina.
So the most important point is in these two. Radicular pain, root pain, more severe in cauda equina. That's a classical. Other one is asymmetric reflexic paraplegia. That's very important. Then sphincter involvement, that is, this is more of this. And symmetry is the rule. Symmetry. So with this point, you will be able to pick up one case and only investigations can support you. That's all.
So just the difference between a spastic and a flaccid paraplegia. So muscle atrophy will be absent or late in case of spastic, whereas in flaccid paraplegia it will be early and prominent. Muscle tone will be hypertonic, whereas in flaccid there will be hypotonia. Motor power loss will be partial, whereas in flaccid it will be complete. Deep tendon reflexes are increased, whereas it's absent in flaccid paraplegia. Clonus will be present and it will be absent. Plantar reflex will be extensor, whereas it's a flexor.
It's good.
So basically it's like a difference between UMN and LMN.
Nice.
So this is the picture demonstrating the difference.
Site of
involvement of the spinal cord.
Tumor.
So here this is the intramedullary within the substance of spinal cord. This is the dura mater. So within the dura mater, it's intramedullary, extramedullary, intradural. Whereas this is outside the dura mater, so it is extramedullary, extradural.
Extradural. Nice. Pictorial representation of what you have told.
Yes. So coming to the common causes. So spinal cord involvement can be a compressive as well as a non-compressive. Can be intramedullary, extramedullary. So most common intramedullary is syringomyelia followed by hematomyelia. Hematomyelia is like acute because it's vascular, whereas syringomyelia is subacute chronic. Coming to extramedullary, it will be either intradural or extradural. Like sir told, intradural can be meningioma, neurofibroma or abscess. Extradural will be extradural abscess, pod spine, metastasis or fracture.
Yeah, another non-compressive important groups are
non-compressive myelopathies. So if it involves the anterior horn cell, it's motor neuron disease, MND. In case of patients who are vegetarians, posterior column involvement will be there, subacute combined degeneration. That is also easily correctable cause of nutritional cause of paraplegia. Then multiple sclerosis, vascular cause, any involvement in the anterior spinal or posterior spinal artery, letharism, it's a toxin, then hereditary spastic paraplegia and transverse myelitis.
So our case belongs to a degenerative disease, so predominantly motor. So it is a non-compressive myelopathy and it is possibly hereditary spastic paraplegia. So these are important causes you should know. Nutritional causes, demyelinating causes, vascular causes, poisons, and again this is also same only, spondylospastic. Then transverse myelitis. All these are non-compressive myelopathies.
So each difference in history wise as well as examination. So the onset in extramedullary extradural is rapid because in case of any fracture to the vertebral column or it's an epidural abscess like pod spine, everything will be more acute in onset, whereas extramedullary as well as intramedullary will be slow. Intramedullary can be rapid in case of hematomyelia. Spinal tenderness will be commonly present because there is a pathology involved in the spinal cord, whereas in extramedullary, intradural and intramedullary it will be rare or absent. So root pains are also common in case of an extramedullary extradural, whereas is uncommon or absent in the other two. Position sense involvement, as I mentioned in that diagram of the spinal cord, because of compression there will be early loss, whereas in case of extramedullary intradural and intramedullary it will be later involved. Pain and temperature also, as I told, it will be lost in almost everything in extramedullary as well as intramedullary, but the pattern of involvement will be varying. So in case of an extramedullary, more of lower limb will be affected first followed by upper limb, whereas in intramedullary upper limb will be affected first followed by lower limb. Sacral loss will be early because I told that representation from inside to out, cervical, thoracic, lumbar and sacral. So it will be early in case of an extramedullary, whereas in extramedullary intradural it will be seen where there will be sacral sparing in intramedullary because it will be the last portion to get affected. Bladder involvement is usually late in case of extramedullary extradural and extramedullary intradural, whereas it is early in case of intramedullary.
So that is very important. These 2 points are very important. When you suspect intramedullary, sacral sparing and early bladder. Because the bladder fibers are towards the center.
I'll just tell that image. So bladder fibers will be predominantly here. So in case of an intramedullary, this will be affected early compared to the extramedullary as well as intradural.
Good point.
So this is the representation. These things should be important. This is the opposite to this. So posterior column, everything will be involved at the same time, whereas in spinothalamic and corticospinal, intramedullary will affect the upper limb first, followed by last is the lower.
Again, depends from where that compression occurs. Yes. Okay. If it is from that area or this area,
from inside,
like that.
So cervical followed by thoracic, lumbar and sacral. If it's from outside, predominantly it will be lower limb, sacral followed by.
So thank you. Please read more about paraplegia so that you can prepare better for your examination. And corresponding theory part will contribute more. So reading the basic subjects means related topics will be very important when you prepare a case of paraplegia. So we'll discuss more cases subsequently. Thank you. Thank you, Manoj, for the nice presentation.
Thank you.